based at the Lancashire Teaching Hospital. He's also the president of the European Association of Bronchology and Interventional Pulmonology. He's led the COVID response at his organization and has been an international speaker on the subject of COVID-19 in the past 12 months. So we're very glad to have him here to give us an update, and I hope that it's going to be an interactive session. It's open to people outside the Association of Cardiologists, so hopefully we'll have a wider audience. So I'm going to hand over to Ahmed Shoaib to lay down some rules, and then Munavvar, all to you. Thank you.
Thank you very much, Dr. Nishtar. Thank you very much, Dr. Munavvar. There is some housekeeping rules, and I just want to share that with you before we can start the formal presentation. First of all, I am thankful to Dr. Mohammed Munavvar on behalf of Association of Pakistani Cardiologists UK. And there are some housekeeping rules. Please make sure that your microphone is on mute unless you are asking a question. Please raise your hand if you wish to ask the question or submit your question in a chat box. It's better you put a chat box and then we can ask those questions to Dr. Munavvar. On the end, everyone will get a chance to ask if any burning questions or if any unanswered thing. A link will be provided at the end of webinar for feedback, and you can either scan a QR code through your mobile or copy the link into your browser. I will also put that on the feedback as well, on the chat box as well. Certificates will only be emailed following completion of the feedback form. Actually, when you go through that link, you will see a feedback form. You can fill the form, give your email address, and then you automatically receive the feedback certificate. The link also be shared in the chat box, and the link will not be available after the meeting. Please make sure that you remain at the end of the meeting so you can get the certificate. Here is the link. I will give 30 seconds if someone want to scan now, and then they can complete the feedback at the end of the session. If you go through your mobile, you can go through this one, but obviously I will put on the end, and you need to fill at the end so you can give a feedback, which is important to us to improve our sessions. Thank you very much. I'm stopping here now and giving mic back to Dr. Munavvar to start this meeting formally.
Okay, thank you very much indeed, Jazakallah Khair, Shoaib and Salman Bhai, for the very kind invitation and words of introduction. It is an absolute pleasure, delight, and honor for me to be here amongst you and to be asked to speak on a subject very close to my heart, which is COVID. I hope you can see my slides now in full view. Is that correct? Or?
Yeah, it's full view now.
Okay, perfect. COVID, as you know, has been with us for more than 18 months, and I must congratulate you for setting up a webinar on COVID. It's of immense importance. The subject of COVID has expanded tremendously and dramatically in the last 18 months, and I'll show you why in a few minutes. And I have tried to put down the following headings under which I will cover this topic. It's a massive topic now. I remember the very first talk that I gave in a China-Europe symposium in April 2020, when I had to speak for 20 minutes and I was trying to find enough literature to speak on the topic. And now one can actually go on to speak for hours together on this topic. There is so much literature, as I will demonstrate to you in a few minutes. However, what I'm going to provide to you is a whistle-stop tour, a comprehensive, hopefully, overview, a summary of where we are up to with COVID under the following headings. A very brief introduction, a touch on clinical features, which all of you will know about, home management of COVID anywhere in the world, hospital management as we do in the UK, a brief overview of the specific therapies and trials, which is of greatest importance to everybody, usually in webinars. I will mention COVID follow-up and prevention of COVID infections, and then conclude the topic. All this in the next 30 to 40 minutes before we go on to the Q&A session. COVID, as you're aware, has been marching relentlessly through the globe, leaving a trail of devastation, despair, and death, as you can see here, around the world. And world over, there have been 8 million plus deaths. And as you all will agree, this is likely to be an underestimate. In some countries, it is more accurate, as perhaps in the UK. I'm sorry, I mentioned 8 million, more than 4 million, but the rough estimate is that it could be more than 8 million deaths around the world. On paper, we have 4 million deaths. And in the UK, it's a little bit more accurate. I would say about 128,000 have passed away. Some of the other countries, they think is much higher figure than what we see here. And I mentioned the top countries and also included countries like Bangladesh and Pakistan. And you would see they have been quite significantly affected as well with COVID. And if you look at the number of deaths, the way it's varied in the UK, the first wave, the second wave, and now we're seeing a slow increase in the number of deaths. And this sort of picture has been seen in other countries as well. This is the figures from Pakistan, showing the number of deaths varying in the form of first, second, and potentially third wave as well. Evaluation of COVID requires a very systematic approach because the clinical features can provide a spectrum of manifestations varying from asymptomatic disease. The exact incidence of asymptomatic disease is unclear from data. We have some data from, for instance, a cruise ship where an outbreak occurred and 18% were true asymptomatic individuals when they were tested. But when they are symptomatic, more than 80% are mild to moderate COVID and could be treated at home itself. About 14% are severe and just under 5% have critical illness. So these people will probably require hospitalization. And the phases of COVID, if you look at the first phase, is the viral response phase. Usually within the first week, there's viral manifestations of COVID. And then there is a pulmonary phase, and then the dreaded host-inflammatory response phase, where the patients start to deteriorate quite rapidly. And the symptoms of COVID are very well known to all of you, so I won't go through in detail. But what we have to observe and remember is that there can be extra pulmonary manifestations involving virtually every organ in the body. And when you examine a patient with COVID at home, you got to observe two things. One, respiratory rate, and two, SpO2. I put this together because there are some patients who can be hypoxic and not be aware of it at all, what we call as happy hypoxics. When they come into hospital per se, then many of them, many of the hospitalized patients can develop ARDS type picture, but there is another type of pneumonitis which we also see in intensive care. So respiratory failure can be due to two types. One is called the low elastance type, and then the high elastance type. So this is an understanding we came about in COVID a little bit later in the illness. In the first few weeks, it was not clear that there were two different types. Non-respiratory organ dysfunction, again, not to be ignored, particularly coagulopathy, which can be a cause of severe morbidity and mortality, renal failure, liver dysfunction, and I don't need to tell this learned audience about potential cardiac manifestations, anything from asymptomatic elevation of troponin to asymptomatic ECG, or even imaging abnormalities on echocardiogram, MR, etc. And symptomatic disease, which can vary from myocardial injury to some myocardial injury to myocardial infarction, myocarditis, which has been described, and even stress cardiomyopathy, Takotsubo cardiomyopathy has been described, besides a number of other cardiac manifestations, either related to COVID or complications of COVID. There are other problems like hyperinflammation syndromes and even COVID encephalopathy. Most of these complications are rather more common in patients who are over 50 years of age and have risk factors such as obesity and other comorbid conditions around the body. However, more recently, with the older people being more effectively immunized, we are seeing younger people with complications of COVID. Coming to laboratory and imaging evaluation of COVID, the classical finding when it's present is lymphopenia. Then some of them have non-specifically elevated CRP. In fact, vast majority end up having CRP elevation at some point in the illness if they are hospitalized. And some of them have deranged LFTs and renal impairment and elevation of LDH. Quite a few have raised D-dimer, and ferritin is another marker, which I'll come to in a minute. CPK may be elevated, troponin, as I mentioned already, and a surrogate marker of secondary bacterial infection, because COVID is a viral infection, a surrogate marker is procalcitonin. In our hospital, routinely, we carry out procalcitonin and also interleukin-6 because it's a prognostic indicator. The other markers of severe illness are high neutrophil lymphocyte ratio, low albumin, elevated troponin, raised D-dimers, and ferritin. These are all surrogate markers of severe illness. COVID swabs are carried out routinely now. In the initial part of the pandemic, it was difficult to get COVID swab. Now it's routine, available freely, and a chest X-ray. Chest X-ray classically can show bilateral patchy consolidation, very typical, along with any features of COVID as far as systemic symptoms are concerned. Very occasionally, we perform CT scan of the chest. In this country, I know in some countries, it's a routine examination as soon as they enter A&E. And on CT scan, no doubt, there are a number of classical patterns. There's the focal ground glass opacification. There is extensive bilateral patchy consolidation or opacification of ground glass. In fact, almost like what we call as crazy paving, which is seen in pulmonary alveolar proteinosis classically. There are air bronchograms and even sometimes pleural effusions. In a small number of selected cases, we would perform a CTPA scan, and CT chest is performed only in patients who have complications related to COVID. So procalcitonin, I alluded to earlier, incredibly important investigation. We perform it on admission to tell us whether there is any chance of there being a secondary bacterial infection. It's a good surrogate marker and indicator of a bacterial infection. We test this on arrival and after 24 hours, because if they are negative on arrival, then after 24 hours, it will help us to see whether there is a rise in procalcitonin and therefore whether secondary bacterial infection is present and antibiotics are indicated. And we continue to monitor procalcitonin because it's better than CRP in this particular. And also, if you get a raised procalcitonin, you do a full screen to look for secondary bacterial infections, including urine for Legionella, cultures, mycoplasma, serology, etc. So that's about clinical features. Now, moving on to the third section, which is home management of COVID. Just one slide on this to summarize home management. We need to remember that COVID is highly infectious, and therefore we need to isolate the patient and the contacts as soon as a suspicion of COVID arises. And PCR immediately. As a matter of urgency, we carry out COVID swabs, and the management besides that is paracetamol, plenty of fluids, and effective hydration. The most useful investigation at home is oximetry, SpO2 measurement, and you've got to set your targets, because baseline SpO2 may be 97, 98%. If it drops below 94%, then alarm bells should ring in most patients, unless they have underlying chronic lung disease, where the target can be set a bit lower. Proning is often neglected intervention, and in fact, the most effective intervention in COVID, better than most medications, is a simple technique which you can learn. Everybody can learn from leaflets or videos on internet, and this can be practiced at every stage of the illness, including when they get into critical care. Physician contact is useful, GP in this country, or some of the physician contact in other countries. And you've got to be prepared for hospital admission anytime if hypoxia should occur. And patients need to be up and about. It's not all about complete bed rest. They need to do gentle exercises. Medications wise, there's a limited role. There is no effective medication as yet, but the number of trials are still underway in primary care. One particular medication, inhaled budesonide, has been shown to be effective in patients who are at higher risk from complications related to COVID. So 800 microgram twice daily in patients who are over 65 or over 50 with comorbidities. This is on the back of the principal trial from multicenter trial from Oxford, and for 14 days seems to reduce the time that is required for recovery from COVID. Similarly, a more expensive medication, monoclonal antibody, has been tried in many countries. Again, limited evidence, but it seems to reduce and speed up the recovery of these patients, and specifically in people who have a high risk of complications related to COVID, and they need to be within 72 hours of symptoms or within 72 hours of a positive test or within 7 days of the onset of symptom to make a difference. So they're more expensive and can potentially be used for this purpose. Not utilized in this country so far, although trials are underway. Hospital management of COVID. Again, we must remember that this is a viral infection. So symptom control is crucial. Hydration is crucial, exactly like at home. Oxygen. In the hospital also, you set targets. We set targets, very clear targets as to what you've got to do with these patients. Mobility and thromboprophylaxis, crucial when they get admitted to hospital. There's been some debate as to what sort of dose to be used, and we don't know for certain as yet. Proning, again, I cannot overemphasize the importance of proning. Antibiotics, limited role, as I showed you with procalcitonin as guidance. Specific therapies, the only proven specific therapy is dexamethasone. And we'll come to that in a little bit more detail in a minute. Second specific therapy of some use based on REMAP-CAP and recovery trial results is Tocilizumab, a drug which has been hyped very much so around the world, and more so in other countries. It is Remdesivir. And this is a nucleoside analog. This is a medication which I'll discuss in some detail in a minute. And in the UK, what we do immediately is to plan about escalation of care. Are they fit for critical care? And that is based on 3 aspects. One is age. You get points. There's a COVID decision support tool. Second is Rockwood Clinical Frailty Scale. And if it's more than 6 or more, those patients do not do well with the admission to critical care and therefore are not suitable. And then comorbidities. So these 3 factors need to be considered before making a decision. So this needs to be in a collaborative, multidisciplinary fashion. The next thing is oxygenation, effective oxygenation. What happens if the patients are not responding to low flow oxygen? This slide is busy, and it's a topic on its own right, so I won't go into detail, but just an algorithm that we published early on. And this tells us that if the patients have tachypnea and hypoxia, and despite giving them 8 liters of oxygen per minute, and if they are, as I discussed in the previous slide, suitable for critical care, then refer to critical care. That may not necessarily be for intubation and ventilation. And in fact, increasingly, in this group of patients, we would use CPAP or high frequency nasal cannula delivery of oxygen, HFNO, and only if they do not respond will we consider more effective treatment in this group of patients. Those who are not for critical care, we would house them in either the respiratory ward or the respiratory high care unit, high dependency unit. If they have type 2 respiratory failure, which is uncommon in COVID, extremely rare unless they have underlying chronic obstructive lung disease or similar, then they would get NIV. Otherwise, vast majority will receive CPAP or high frequency nasal cannula oxygen. So this is just a very brief summary of how we oxygenate and how we plan respiratory support for these patients with COVID pneumonitis. Coming to thromboprophylaxis, as I said, there's a considerable debate in this area. The vast majority, if you want to be played safe, there are British Thoracic Society guidelines, there's American Society of Hematology guidelines. In short, most patients will benefit from low-dose prophylactic anticoagulation, even if they go into critical care, and a small subgroup of patients may benefit from intermediate dose low molecular weight heparin. Again, this is a separate topic on its own right. You need to maintain a high index of suspicion for associated pulmonary thromboembolism or generally venous thromboembolism. And where the D dimer is trending upwards and there is any other clinical feature to suggest thromboembolism, you need to investigate and then give them therapeutic dose of anticoagulation. If you are interested in more information on any aspect of COVID care, a useful website is the British Thoracic Society website, specifically on COVID-19 for the respiratory community. And in this, around the clock for 3 to 4 months when the pandemic started, a full team worked to produce guidelines on every aspect of COVID, COVID and COPD, COVID and ventilation, nebulizer use, bronchoscopy and COVID, etc., and even renal failure and thromboembolism. And this has been updated regularly, so well worth looking at that website. So that is about hospital management. Now, Shoaib and Salman bhai, everything is clear so far? You're seeing my slides, no problems?
Perfect. Yeah, it's very good. It's going fine.
Excellent. Do stop me if I'm going too fast or too slow or anything at all. I'm very happy to be interrupted anytime.
Yeah, take your time.
Okay, thank you so much. The next section is about specific therapies. There has been, as you would have witnessed, an explosion of literature in the field of COVID. Just a few days ago, while preparing another presentation, I went to the website and looked at the number of studies in COVID, and a whopping 6,000 plus studies have been registered in the field of COVID. It's unprecedented, unheard of. And if you go to PubMed and search articles published with COVID, more than 150,000 publications have already been successfully created, and many of them are available. And as you know, luckily, they are all free of cost. Why? Because so many medications have been tried in COVID out of desperation sometimes, and sometimes because of scientific discussion, consensus statements, and everything possible has been tried. Even recommendations from the president saying that you should be using hydroxychloroquine, as you know, and subsequently, as you know, that it was proved not to be the right thing to do. Anti-HIV drugs were tried. The only medication which stood the test of time is dexamethasone. Azithromycin came and went, as I'll show you in a minute. Tocilizumab possibly still has a role in selected patients. Plasma therapy, hyped, great deal of hype, and then disappeared. Remdesivir, a lot of discussion about Remdesivir, so I'll touch upon it in a bit more detail in a minute. Colchicine, anti-inflammatory, still hanging around, but in the larger trial for hospitalized patients, it's not shown to be effective. Same with aspirin. Regeneron or monoclonal antibodies in general may have a role. I'll come to that in a minute. Baricitinib, a medication used for rheumatoid arthritis, that has also been is being studied still. Dimethyl furoate, again in the recovery trial, being studied at the moment. Nebulized nitric oxide, antiviral favipiravir, interferon beta, ivermectin. I'll mention ivermectin in another slide in a minute because it is used extensively around the world, not in this country very much. Low-dose radiotherapy has been tried. We were involved in a study in Preston. Inhaled budesonide, and we were also involved in a study of nebulized nitric oxide here in a multi-center fashion in Preston. Let's look at some of these. We do not have time to go into all of this, but recovery trial has been the biggest study in COVID, a landmark study and a seminal study. And I'm not saying just because I have not really conflict of interest, but I have the honor and pleasure to be part of the data monitoring committee for recovery trial. So I've seen it in great detail throughout the pandemic in the last several months. So recovery trial initially, the randomized patients were randomized to lopinavir, ritonavir, dexamethasone, hydroxychloroquine, azithromycin, and then a second randomization to tocilizumab and no additional treatment. Later on, azithromycin plus convalescent plasma plus monoclonal antibody, aspirin, colchicine, all of those were added. As you can see here, more recently, you have baricitinib, and this has been stopped now, Regeneron, and you also have dimethyl furoate. And if you see, there more than 40,000 patients have been registered in this study, 177 sites in UK alone, There are a few international sites cropping up now in Nepal, Indonesia, Thailand, etc. What it showed very clearly, beyond doubt, is that hydroxychloroquine does not work and in fact may cause problems in patients with COVID. As cardiologists, you know what the risks with hydroxychloroquine use are very clearly. Lopinavir, ritonavir anti-HIV drug found not to be effective both in the recovery trial and the WHO solidarity trial. Similarly, azithromycin was shown not to be beneficial in recovery trial. Solidarity trial also said that remdesivir perhaps does not work in COVID. Convalescent plasma, a great deal of excitement was around when convalescent plasma was being studied, thinking that this may be the answer, and a number of randomized controlled trials were carried out in this field. As you can see, thousands of patients were studied, and finally a systematic review and meta-analysis concluded, and also the recovery trial concluded, that amongst hospitalized patients with COVID, high titer convalescent plasma did not improve survival or other pre-specified clinical outcomes. Remdesivir. Now, this medication came along on the back of one study, the ACT-1 study, and simply because these patients had a shorter time to recovery. That's all that happened with the study. There was no improvement as far as mortality is concerned or a need for intubation and ventilation. Despite this, remdesivir is pushed heavily and used quite extensively around the globe. The solidarity trial showed that remdesivir does not work, does not reduce mortality, initiation of ventilation, of duration of hospital stay, along with all the other medications that we have already studied. Again, a massive trial, the solidarity trial, with more than 11,000 patients coming to that conclusion. In the UK, the national policy is to use remdesivir very, very occasionally. In fact, in our hospital, I would say less than 1% of hospitalized patients have received remdesivir, and this is to be used only in hospitalized patients who require low flow oxygen, supplemental oxygen, which is low flow, not the ones who go into respiratory high dependency or critical care, just low flow oxygen. They need to be within 10 days of onset of symptoms, not swab result. They need to have a positive swab or the MDT diagnosis. And of course, EGFR needs to be over 30 and ALT less than 5 times normal. So in fact, very few patients qualify and have had remdesivir in the country. What people have had for certain is low dose dexamethasone. And this is ever since the announcement from recovery trial on 16th of June, saying that dexamethasone reduced deaths by 1/3 in ventilated patients and by 1/5 in other patients requiring oxygen. So based on these results, one death would be prevented by treatment of around 8 ventilated patients or 25 patients requiring oxygen. So ever since, dexamethasone has been used at a dose of 6 milligram daily for 10 days, which is the usual dose, although on occasions we extend the dose depending upon how the patients respond. Tocilizumab, an anti-IL-6 very potent drug, was also studied in a number of trials, in particular the REMAP-CAP trial. All the other smaller studies demonstrated no benefit with tocilizumab. REMAP-CAP showed promise, and recovery trial then showed that perhaps tocilizumab can be used in a small subgroup of patients. Who are they? In the UK, we use tocilizumab though in patients who are PCR positive or clinical and radiological diagnosis, CRP greater than 75, SpO2 less than 92%, already on dexamethasone, and importantly, within 24 to 48 hours of high flow nasal oxygen, CPAP, NIV, or intubation and mechanical ventilation. In other words, those patients who are transferred, are just about to be transferred or transferred to respiratory high care or intensive care, at that point, there is a window of opportunity, perhaps, where the benefits of tocilizumab would outweigh the risk, as shown in the recovery trial, as where the curve did separate. Now, big question I get asked repeatedly is ivermectin, especially when we speak in webinars In other countries like South America, India, and the subcontinent, we get asked this question repeatedly because ivermectin is used extensively in many countries around the world. Now, a great deal of debate continues with ivermectin, but what is very clear, and that's the reason why we did not use and do not use ivermectin in this country, the reason is the ivermectin studies go through some points here. There was a huge study from Egypt where the ivermectin efficacy and safety and of it was published efficacy and safety of ivermectin for treatment and prophylaxis of COVID pandemic. Subsequently, they found multiple errors in the study, some raising ethical questions as well, and therefore this has been taken off even the research websites, this particular study. Now, a systematic review and meta-analysis was recently concluded and published, and the conclusion from that recent meta-analysis is that ivermectin did not reduce all-cause mortality, length of stay, or viral clearance in the randomized controlled trials in COVID-19 patients with mostly mild disease. Ivermectin did not have an effect on adverse events or severe adverse events, and therefore ivermectin is not a viable option to treat COVID-19 patients. The European Medicines Authority advises against use of ivermectin for the prevention or treatment of COVID-19 outside randomized clinical trials. In fact, in the UK, the principal trial is in the process of studying ivermectin in primary care at the moment. So we need to wait for more data. As it stands, we would not be able to support its use. Monoclonal antibodies, again, a huge amount of excitement in this area. There are a number of monoclonal antibodies which are available, and monoclonal antibodies are already being used in some countries, particularly in the US, and they have a small role, as I showed you earlier, in patients early on in their list. And recently, the recovery trial showed that they may have a role, as it's concluded here, in patients hospitalized with COVID-19. Monoclonal antibody combination reduced 28-day mortality among patients who were seronegative at baseline. So only those patients, because all participants, when you look at, it did not seem to be appropriate to use monoclonal antibodies. But when you took out those patients, separated in subgroup analysis, those who are seronegative at baseline, monoclonal antibodies seem to work. I'm coming towards the end of my talk, and I just want to present information on two aspects which are often forgotten in most discussions. One is COVID follow-up. You would have heard about long COVID or post-COVID syndrome, and therefore it is absolutely crucial that we have a very systematic approach to look after these patients to prevent as well as manage post-COVID syndromes or long COVID. There are a number of algorithms, number of plans. I present here very briefly the British Thoracic Society algorithm for these patients. And you need to have a respiratory follow-up for all patients with COVID pneumonia who have been admitted. And there are two groups. One group is those patients who have had severe pneumonia, have been in ICU or respiratory high care. And those patients warrant a review appointment, at least a teleconsultation within 4 to 6 hours of discharge. And then at 12 weeks, a further consultation, which is even more thorough. And it requires a holistic assessment, including pulmonary function tests, echocardiogram, maybe a CT scan, either HRCT or CTPA, and so on. And some patients among these will require further follow-up because of pulmonary embolism, interstitial lung disease, or pulmonary hypertension, and so on, many other complications. There is another group of patients who have had mild to moderate pneumonia, and these should not be forgotten. On discharge, they also need follow-up with the COVID specialized follow-up team, and these patients can be followed up a little bit later because of the resource implications. They can be followed up a few weeks later, but again, they need to have an assessment to see whether there is any sequelae of COVID, including possibility of pulmonary embolism, pulmonary fibrosis, and so on. And some of them will require full lung function test, HRCT, CTPA, even echocardiogram. So this is what we need to do, a structured follow-up plan. And for instance, in our hospital, we have a follow-up, a respiratory COVID follow-up team led by my consultant colleague, Dr. Sharada Gudu. She's a respiratory consultant with physiotherapists, respiratory speech and language therapists, advanced nurse practitioners, and a whole team behind them. The idea is to provide holistic assessment and signpost people to appropriate services so that we can confirm that they have recovered completely from COVID. Under prevention of COVID, I need to mention two things. First of all, how do you and I prevent infection from COVID? All of you presumably are involved in intervention. Just to give you an example of my work as an interventional pulmonology, and we have had a very strict and systematic approach to prevent infection, because obviously bronchoscopies, thoracoscopy, etc., they are aerosol generating procedures. So we move to a number of measures, including ensuring that patients are isolated in advance for a minimum of 3 days. Initially, it used to be 7 days prior to procedure. Then a test, a swab, at least 24 to 48 hours prior to the procedure. And in some cases, we also carry out a swab on the day when they arrive. And then we try and do as many procedures as possible under general anesthesia or other alternative approaches to ensure that there is minimal aerosol generation, and full PPE for all such interventions. And we, of course, continue with other measures as well. The final topic I want to mention is COVID vaccines. And you must have heard so much about COVID vaccines. COVID vaccines are absolutely essential. There are so many vaccines that are available around the world. In the UK, the initial vaccines that we use were the nucleic acid vaccine, mRNA vaccines, the Pfizer-BioNTech and Moderna vaccines. Then the viral vector vaccines, such as the Oxford AstraZeneca vaccine and the Janssen vaccine. Other vaccines which are available are the inactivated vaccines, which contain killed SARS-CoV-2 virus, such as the Sinovac and Sinopharm. You also have protein vaccines, Novavax, Sanofi, etc. And finally, attenuated vaccines, which are also in development. So these are some groups of vaccines which are available. Most of the vaccines do about the same thing. The level of protection you would see both to the original COVID coronavirus, as well as against the variants which have appeared. What is very clear with the vaccination is that it reduces the severity of illness and prevents deterioration, hospitalization, and death. So in conclusion, COVID requires a bundle of care. We have to understand that antiviral effects are there. I've discussed about Remdesivir, a very limited role in COVID. Most important is best supportive care, need for anti-inflammatories such as dexamethasone, anticoagulants, adequate support, respiratory support, some role for antibodies in COVID. Just to recap, I've gone through the importance of supportive therapy at every stage of the illness. Watch out very cautiously for hypoxia and tachypnea. And in the hospital, always have senior input to the management of COVID, effective oxygenation, early proning, and even late proning in every stage of the illness, respiratory support as appropriate, including CPAP, HFNO, and very occasionally intubation and ventilation. Risk stratify patients on arrival based on CFS, a clinical frailty scale, comorbidities, inflammatory markers, set targets and escalation plans. Don't forget clots, kidney function, and other problems such as cardiac complications. A very close collaboration with the critical care unit and the entire multidisciplinary team is crucial to get the best results. Specific therapy, almost everybody who comes into hospital who is hypoxic will need to be given dexamethasone. Dexamethasone is not to be given out of hospital if they are not hypoxic. Small role for Tocilizumab in selected patients, as I mentioned, those who are deteriorating despite oxygenation and require intensive care. Within that 24 to 48 hours, they need to be given Tocilizumab. Very small role in Remdesivir in early patients with COVID. Enroll in RCTs. This is crucial. Evidence is key. Although we know a lot more about COVID than we did a year ago, we need to learn more. So continue to recruit to various trials, such as recovery, which I've highlighted, REMAP, CAP, etc. And not to be forgotten are those patients who have recovered, because post-COVID follow-up is pivotal, because a plethora of potential problems can be can arise and need to be addressed. And I cannot overemphasize the importance of prevention, precautions such as social distancing, masking, and sanitizing, and the importance of getting vaccines, and all, not just us, but ensuring that this happens around the world. And therefore, it's important to have a global approach to management of COVID, because no one is safe really until everyone is safe, certainly when it comes to COVID. Many thanks indeed for your very kind attention.
Thank you very much, Dr. Munawar. I would like to ask now questions and picking from the chat box. Some questions you have already covered, but some maybe still need to answer. There's the first question: any role of aspirin at home treatment, and the same can they given be apixaban? Probably you have covered, but apixaban you didn't.
Yeah, very good question and very practical question. In the recovery trial, we studied aspirin, but of course, those were in hospitalized patients. And there, it didn't seem to make a material difference to the outcome in patients with COVID. And therefore, we don't use it in the hospital. As far as in the community is concerned, there is some degree of debate. As it stands, there is insufficient evidence, and it's a question of weighing very carefully the benefits versus risks of aspirin therapy. It's not routinely recommended, certainly in the UK, but I can understand in some countries, because it's a cheap available drug, people tend to use it. Similarly, for apixaban, there is no conclusive evidence for the use of apixaban. Certainly in primary care, in early cases, there is no evidence for its use. We have to weigh the benefits versus risk. Even after severe illness, when they go home, there is some debate, and the American Society of Hematology recently have studied to very carefully weigh the benefits versus risk, and it's not to be taken lightly, the use of apixaban. Having said that, most patients who go home after hospitalization, if they are at risk of thromboembolism, after doing a risk stratification, we do provide them with anticoagulant therapy as it stands, and that can be low molecular weight heparin or apixaban.
Okay, there is another question: any role of vitamin D and zinc in prophylaxis?
So vitamin D and zinc. Vitamin D, they're again, these agents have not been studied. They have been used because there is a hypothesis that vitamin D deficiency can increase the risk of COVID and risk of complications in COVID. So there is no harm done by giving vitamin D in those patients. Zinc, there is no evidence at all, but again, there's no harm done. It's all about benefits versus risk. Problem is, these agents have not been studied systematically, and therefore, if people ask me, I say no harm in taking them.
Okay, and there is another question: what proportion or percentage of people develop fibrosis? I think so they mean to ask after hospitalization, probably.
Yeah, excellent question. And we're still looking at data and studying this. And this depends, seems to depend quite a bit upon, to a certain extent, on severity. But various estimates have been put forward, and we think amongst hospitalized patients, this can be as high as 5 to 10% incidence. But a lot of data, there's the international collaborative collecting data on fibrosis. But as it stands, we look for fibrosis in every single patient who has gone home. I've talked about the post-COVID follow-up, assuming that close to 10% will, if not more, will develop fibrosis.
Just a minute. And there is another question: what vaccination is effective against Delta virus?
Right, a superb question. There is ongoing work. There is a team studying this, and also a team trying to tweak or modify vaccines to deal with this. As it stands, the vaccine.
Oh, sir, come here.
Sorry, Alvina, can you? Yeah, you can.
Okay, no problem. As it stands, both the Pfizer and the AZ vaccine and also the Moderna vaccine have all been shown to be effective even in the Delta virus, as far as reduction of severity with illness and morbidity and mortality are concerned. Transmission-wise, we don't have data, but certainly all of these vaccines are effective. Yes, admittedly, their efficacy was found to be in some work, it's found to be slightly lower than the original variant, but definitely effective still against Delta virus.
And role of prednisolone in perfenidone. Role of perfenidone in stopping post-COVID fibrosis.
Okay. Again, excellent question. Perfenidone it's an antifibrotic drug, and it's been used extensively in idiopathic pulmonary fibrosis. Both perfenidone and the other medication, which is often used in this area, the nintedanib, both of them have been tried, but we do not have conclusive evidence as yet, either in prevention or treatment of post-COVID fibrosis. There's a great deal of work underway in this area, and we have to watch the space. I know that in the meantime, in some countries where it's freely available, it is being used, not in the UK as yet. They have to go through the pulmonary fibrosis MDT, and as it stands, it is not being used as far as I know.
There's another question. Once vaccinated with Sinopharm, can Pfizer or Moderna vaccine can be given in addition?
So this is an area we don't have enough information on, certainly not with Sinopharm and other vaccines. There is a study where Pfizer vaccine, people were given Pfizer vaccine and then given AZ vaccine, or people first dose of AZ and then Pfizer vaccine. There is a view that potentially, certainly when it comes to the booster dose later, using an alternative vaccine to what you received first time around may help. However, WHO scientists are skeptical about this. In short, we do not know as yet. But we have no data when it comes to, as far as I know, I have not come across any data with regard to other vaccine mixing and mixing other vaccines such as Sinopharm.
And what's about the mixing of our AstraZeneca and Pfizer?
Yeah, so as the JCVI at the moment recommend that it's if somebody has had a first dose of AZ vaccine, they need to have the second dose also as AZ vaccine, unless they've had some problem with the first dose. Similarly with Pfizer, first dose is same as it stands. You need to get the same. However, there is, as I mentioned, there is a study where the vaccines have been mixed. The volunteers have had either first dose Pfizer and second dose AZ, first dose AZ and second dose Pfizer, or the same vaccine on each occasion, and those people are being followed up. There is some suggestion that you might get a slightly greater response, but there's no conclusive evidence as yet. For now, JCVI, the Joint Commission on Vaccination, COVID vaccination, recommends that you continue with the same vaccine for the second dose.
A very important question from the Bilakshmi Bhai. With the Eid coming and at 19th, the 20th July, with ease of restrictions, what should we do as medics advise our community?
I'm sorry, I missed some of that. There is
just a minute.
Sorry, Shoaib.
Any special precautions on Eid? That was the question.
Oh, special precaution Eid. Okay.
People were mingling quite a lot.
Okay, very good question. What I always tell people is, if you, for any occasion, if you're going for any occasion, for instance, I'm about to go for a reception just after this, all of us carry out a lateral flow assay before we go. And I think we should be doing the same on Eid day as well before meeting people. And we should continue with precautions as we have been doing throughout, particularly most of us who are working in the medical field, because we are at higher risk of having picked up the infection. So strictly speaking, we should continue with precautions, especially if you're going to be meeting people who are more vulnerable. And if you have not been double vaccinated, I would recommend that you continue with stricter precautions and don't take any chance at all. I look after COVID patients, and only this week I have had to send patients who are 28-year-old, 30-year-old, 34-year-old to critical care. And all of them have not had both the vaccinations. So it's a real danger still, which is lurking around. For Eid, I would say, take all possible precautions. That's the safest route.
Sorry, there is a question. What's the target level of oxygen you will go for inpatient settings?
Inpatient setting.
Yeah.
So the standard target, as long as you do not have any oxygen supply issues, the standard target, I say that for a particular reason, but the standard target should be 94% to try and maintain it above 94%. However, if you have underlying chronic lung disease or any condition which leads to carbon dioxide retention, that target can be reset at 88% plus. I mentioned about oxygen supply issues because even in the UK, very early on in the pandemic, you may have heard that the oxygen levels, there was a concern that the use of high flow nasal oxygen, which requires several liters of oxygen, high flow nasal oxygen was starting to affect oxygen supply issues. And therefore, we did two things. We switched from high flow nasal oxygen to CPAP, continuous airway positive airway pressure, in those who are deteriorating. And number two, we also reset the target to 92% or lower. It all depends upon what the baseline of the patient is. If the baseline of the patient is 98%, for instance, you will definitely aim for 94% plus at rest. So I hope that answers the question.
Yeah. Another very important question and very interesting. This fibrosis is reversible or not in severe cases? And is there any treatment for fibrosis or not?
Okay, and this we are not entirely certain about because quite a few patients actually seem to improve after what appears to be initial fibrosis, and whereas others seem to progress. It's still early days, and we do not have enough information in the world of post-COVID fibrosis. So that's the reason out of desperation, people use antifibrotic drugs, but it should be done after very careful assessment, careful evaluation, and planning in a multidisciplinary setting.
How long steroids should be given whose oxygen demand not falling, and those admitted with more than a month? Actually, it's a long-term steroid use.
Okay, so absolutely brilliant question, because traditionally, certainly in the UK, we've used dexamethasone 6 milligram for 10 days on the back of the recovery trial protocol. However, one needs to bear in mind that some people continue to require oxygen, and we should not be applying steroids at that point. We will have to weigh the benefits versus risks and continue steroids till they become independent of oxygen. It's a double-edged weapon, steroid. As you know, giving steroids very early on before they become hypoxic, especially in patients with diabetes, has encouraged people to, has actually triggered the onset of other complications, diabetes-related complications, as well as fungal infections. You would have heard of a number of cases of mucormycosis around the world, particularly in India, a large number of reports of mucormycosis. And we believe that that is because steroids were used in very early, in higher doses, and in patients with diabetes. That certainly proven to be the trigger in those patients. So in short, dexamethasone is available, if available, 10 days, but if the patient remains hypoxic, you can continue longer. In some patients who have extensive changes in the lungs and they are in critical care and deteriorating, originally, in some of those patients, occasionally we use even methylprednisolone pulses. In some patients, if you do not have dexamethasone, in some countries, prednisolone is used in that scenario as well for COVID pneumonitis. So all of these need to be bear in mind. You have to individualize cases and bear the benefits versus risks in mind.
And do we need to do tapering after 10 days, or we can stop straight away after use of?
and again, an excellent question, because in the recovery trial, the protocol was to stop at 10 days. Now, clinical practice, you have to carefully, again, weigh the benefits versus risks. Because it's a short course, you don't need to do tapering from that point of view, from an adrenal insufficiency point of view. There is a practice in some people, if they have persistent cough or some residual changes in diabetics, rather than giving them dexamethasone for a prolonged period, there is a tendency to switch to inhaled steroid beyond it, like how we've done the trial with the budesonide, which I've shown you in the principal trial. That is sometimes used in people. This is not backed up strongly by literature, but it's something that we sometimes use in some countries, not so much in the UK.
You've already covered this question, but you can quickly answer because it's already on the board. Is there any role of rivaroxaban/DOAX in elderly patients who are not hospitalized for thromboprophylaxis?
Yeah, we do not have any scientific evidence to back that strategy. And so it's very difficult to recommend it. And when you weigh the benefits versus risks, there is no proof that it's going to benefit. So the risks will be high. So as a general rule, effective hydration and trying as best to mobilize these patients is probably a better option based on current. Having said that, there may be the isolated incidents where you have patients who have very poor mobility as baseline. You're worried about thromboembolism, and then you have to weigh the benefits versus risk and potentially try in those patients. But there is no scientific evidence to back that up, I'm afraid. The absence of trial. It's one of the scenarios where lack of evidence of benefit does not equate to evidence of lack of benefit, as they say.
It's an interesting question. COVID vaccine for patient on chemotherapy for hematological malignancies, or I can rephrase it. Is there any particular vaccination you go for these set of patients, and other vaccination you will recommend for those set of patients?
Yeah, so this we have to work very carefully because there are a number of nuances involved with this, with a particular type of hematological malignancy, with a particular chemotherapy, with a particular stage of chemotherapy. But overall, as a general rule, the mRNA vaccines have been used more extensively in that group of patients, but it's a close collaboration with the hematology specialists, and based on the treatment, you have to plan very carefully.
It's a question from Dr. Mughal. If I'm not wrong, he's my medical college friend. Any update on vaccination in children? He's a pediatric cardiologist. And the second question is that what is sensitivity and specificity of later flow test? Please, as we see loads of discrepancies in LTFT and PCR.
Yeah, superb question. First question is about the vaccination in children. There are studies underway with regard to vaccination in children at the moment, and we do not have definitive evidence. However, as you know, that in some countries they have started to vaccinate even children, particularly those who are 12 to 18-year-old. It's not a strategy which has been approved as yet in the UK. The second question is about, and so we have to wait for the data from the study which are being undertaken in children, particularly the 12 to 18-year-old. And that's going to be crucial for this pandemic going forward, because most of the infections that are occurring, for instance, in the UK at the moment, are in school children and younger individuals. So it's going to be important to see that. Having said that, most of them are not getting severe illness and not getting hospitalized. The second question about lateral flow assays, the lateral flow assay, the sensitivity, depending on what lateral flow assay you use, the ones that we use here, the sensitivity and specificity are very high, 99% plus. In fact, the false positive rate was down to 1 in 1,000 in lateral flow assay. And that has also been further improved more recently with the current LFAs which are available. And there is a very strong correlation between the lateral flow assay and the PCR, the swabs after that. We have seen it in our own institution. We have in our hospital, we have 7,000 staff. Over a period of time, over several weeks, there were 300 to 400 positive lateral flow assays, with everybody undertaking the test almost on a daily basis. And all of those turned out to be positive on PCR as well. So it depends upon what lateral flow assay and what swab you do, and there are so many nuances with these swabs as well, and how you conduct the lateral flow assay, because it's a self-swab technique. So if you don't take a swab properly, then the assay can give you a false negative result. So a lot of steps involved with it.
And patients on chemotherapy, when they can get vaccination?
So this again, you need to collaborate very closely with the because it can vary from whatever type of malignancies and what type of chemotherapy they are receiving. So you've got to plan carefully. But as a general rule, they are encouraged to get the vaccination sooner rather than later. It should not interfere as long as there is no severe thrombocytopenia, severe pancytopenia at that time. And even so, with the vaccines, even on oral anticoagulants, they found that with this, because it's a 25 gauge needle, it's a tiny needle, and with pressure after the vaccination, there's not been much of a problem. With regard to hematological malignancies, you have to liaise with the specialist and choose the vaccine also carefully for that purpose.
There is another question. COVID-19 is a mild disease in children, but there is more serious condition, PIMS, recently characterized in children. Are you aware of this and any measurement in brief?
Yeah, so yes, indeed. I mean, I think the recovery trial, which I keep mentioning, this has been extended to children. Unfortunately, none of the children have come to any serious harm. And these children are also being studied in the recovery trial in form of steroids, which have been used because originally this was thought to be somewhat similar to the Kawasaki disease. I do not manage children. I'm an adult respiratory physician, but I've seen it as part of the recovery trial because, as I mentioned, I'm in the data monitoring committee, so I see the data coming through. The study is underway in children, and hopefully we'll have more results in due course.
Dr. Munavvar, there are a lot of questions. Are you happy I can ask these questions, or
yeah, go ahead. No,
so,
not at all. I'm very happy. I'm here to.
It's a lot of interest among the audience. I'm really surprised. I'm really happy as well. How long steroids should be given whose oxygen demand not falling? Oh, sorry, I already asked this question. Just a minute. There is a question, if any patient received 2 doses of Pfizer vaccine, again infected with COVID-19, what plan need again for booster dose of vaccine, please?
Again, excellent question. So when they've had 2 doses of the Pfizer vaccine, the chances are they will have a mild illness after they have been double vaccinated, provided there has been a window of at least a week or 2 weeks, ideally, after the second dose. They are likely, almost certainly, will have a mild illness from which they will recover. And what to do beyond that, after that, has not been studied. There are some early results, early data to suggest that they will also, like anybody else, require a booster dose. In the UK, the booster dose is planned in a few months. It could be in autumn or just beyond. So the fact that they have had an infection after 2 doses of Pfizer does not mean that they have not been protected, because Pfizer, or indeed any vaccine, does not prevent transmission, does not prevent infection completely. What it does do is to reduce the severity of the illness and prevent death to a large extent. So if they offered a Pfizer vaccine again after that, they certainly can take it as a booster, or if they offered another vaccine, they can take that.
There's another question. Can SLE patient take Pfizer vaccine?
Should be able to. Again, for specific conditions like this, it's very important to liaise with the specialists dealing with the condition. I am not aware of any specific contraindication, but it's something that need to liaise with. If at all, with the AZ vaccine, that is where a degree of thromboembolism was seen, and if at all there may be a concern with regard to AZ vaccine, the Covishield or AZ vaccine. rather than Pfizer, where this has not been seen. With the Pfizer and the Moderna vaccine, as you will be aware as cardiologists, there were some reports, there's concern about potential myocarditis, cardiac complications that has been discounted by the specialist societies. But specifically with SLE, I'm not aware of any contraindication.
Actually, they want to, Dr. Faraj Jabin is here. She want to ask patients who are on hydroxychloroquine for SLE patient. That's a particular question, actually.
Oh yes, yes. Oh yeah, they can receive the Pfizer vaccine. I'm not aware of any contraindication to receive an mRNA vaccine if they are have SLE and hydroxychloroquine.
And there's another question from Dr. Mughal. Any consideration of additional booster in immunocompromised patients?
Yeah. Again, these are very, very good questions because, but we do not have clear answers based from scientific evidence. But these patients who are immunocompromised will be first in line for the booster. That is clear. When they start the program in the UK in autumn, I think they'll call upon those people who are immunocompromised, who have had to shield previously in the previous year. They will be called upon first to receive the booster. I'm pretty certain about that.
And there's another question from Dr. Qazi Salim Ahmed. Any role of saline nets or steam inhalation?
And so there is no scientific evidence to support either saline or steam inhalation. Saline inhalation or nebulization is used as a mucolytic effect, and that is used in patients with airway disease. And in COVID, airways are not affected to that extent. It's more of a pneumonitis in a peripheral setting. The consolidation also is peripheral, and therefore neither saline nor steam, which is often recommended, is of any clear scientific benefit.
There is a question from Dr. Raja Faisal. He's again my class fellow and presently working in Qatar. He is saying, is post-Pfizer cardiomyopathy in young children worsening issue?
Post-Pfizer cardiomyopathy. So this has been a subject of some discussion and debate, and I think all of you may be better informed than me. I have read about it, and there were concerns expressed, and there was a lot of dialogue in journals about and specialist societies about concern of post-Pfizer messenger RNA myocarditis cardiomyopathy. And actually, when they analyzed the data, they did not see a particularly higher incidence than what is present even without COVID or a standard incidence is what the conclusion was at the end of all the discussion. But this is something that is being monitored very closely by specialist societies, by Pfizer-BioNTech themselves, and they made a statement as well about that, I think.
There is a question from Dr. Alia Kidwai. After you had one vaccine dose of Pfizer and then get Delta, how soon you have second dose? It means that first dose of Pfizer was 4 weeks ago.
Fantastic question. So this depends upon where you live, because actually if you have a second, in the UK, you give a 4-week gap after recovering from the Delta variant or indeed any form of COVID. But in the US and in many countries, you have to give a gap of 3 months prior to getting the second dose. There is clear evidence that after you've had COVID, if you receive the vaccination, you get a much better antibody response. And I presume there'll be much better T-cell response as well. So if you're living in the UK, 4 weeks after that, after you recover, you'll be eligible for the second dose.
There is a question from Dr. Abdul Hanan Hamid. Does COVID infection provide some sort of immunity as post-COVID, the antibodies titer are quite high? And how long these antibodies last for?
So again, all superb questions. And unfortunately, we do not have enough scientific evidence for me to give you a definitive answer. And therefore, I do apologize if I'm sounding a bit vague, because what we know is that the antibody response, post-COVID antibody response, varies quite a bit. In some people, it seems to last several months. And in some people, the antibody measurements, antibody checks show that they, even after COVID, sometimes the antibody titers are not very good. Antibodies post-COVID, you must remember, there are actually 4 different types of antibodies, and the most commonly studied is the nuclear capsid antibody to the nuclear capsid antigen. That was the initial Roche antibody, etc., that we were testing. But a post vaccine, you get also a spike protein against a spike protein antibody. So when you do an antibody titer, if you do a quantitative titer, then you will be able to see the degree of rise, particularly if you have the facility to a quantitative titer following COVID. So it's variable. It's between enough that you'll get at least 3 to 6 months. It may be a lot longer.
Yeah, because now we are going to end. I will invite Dr. Abdul Wahid. He can ask the questions now, and after that, Mubashir. He is a consultant orthopedic surgeon in London. He's again my senior in medical college, and I'm seeing him after probably 30 years or so, or 25 years. Yeah, Dr. Wahid, you can ask the questions directly, and people after that they can ask. You need to unmute. Dr. Wahid, you need to unmute yourself. We can't hear. The question from Dr. Wahid is AstraZeneca associated with high rate VTE phenomenon?
So there was concern in younger individuals that some unusual complications, thromboembolic complications, what we call as vaccine-induced thrombocytopenia and cerebral venous thrombosis, etc., were reported. This was reported in some countries in Europe, and also a lower incidence. But actually, the incidence is very, very low, and equated to about 1 in 250,000 incidents. And therefore, the government moved to gradually increase the age under which over which the AZ vaccine should be given. So in some countries, it's over 55. Here, it started with over 30, and then over 40, and so on. In short, the incidence is low, and there's not much that has been reported since the age cutoff was increased for the AstraZeneca vaccine.
It's now last 1 or 2 questions. Now, Mubashir Ahmed has raised his hand. Mubashir Ahmed Malik, you can ask the question directly to Dr. Munavvar. Mubashir Ahmed?
Yes, yeah. I'm Dr. Mubashir Malik from Pakistan. I am 68 years of age, and I want to share that I had my Sinopharm first dose on 14th March 2021. 3 days after, I had a reaction delayed, something like that, and I was hospitalized. All the tests were done, and everything was negative. Even I got this nasal and throat and all those. And there was none of the positive, but my antibodies test were good, reasonable. And I suffered for about 2 months. And I wanted to know, do I have to get second shot? Because since then, now till now, I am getting messages that get your second shot is ready. Can you please advise me?
Okay. So very good question, Dr. Malik Saab. I'm glad to hear that you're better after that episode. You said after the first dose of the vaccine, Sinopharm, 3 days later you developed symptoms, and was it proven to be COVID? You said the swabs were negative. Did we get a antibody test to the nuclear capsid antibody, do you know, to see whether this response of the antibody was related to COVID or to the vaccine? Because that will be crucial to determine what has caused the illness. Within 3 days, normally we would not expect that much of an illness after a vaccine, although Sinopharm is not one of the vaccines which has been extensively studied or published certainly in our literature here. The answer to your question is, as a general rule, if you think it is related to the vaccine, if it is felt it's related to the vaccine, then it is preferable when you get a chance to get an alternative vaccine rather than Sinopharm. And the recommendation would be to get either the Pfizer, Moderna, I don't know whether it's available there, or something which is more extensively studied. I think Sputnik V has been studied to a greater extent, although we don't use it in the UK. So that would be the recommendation. It still would be recommended that you get a vaccine after a few months. You leave it at least 3 months before you get another vaccine.
Dr. Munavvar, I think so we are already over time. It's a last question, and after that we can close the topic. I will invite Dr. Nishtar to close the topic now. It's a last question from Charles Amilafula. The proning in COVID patient, is it any different from the usual lateral prone position? Now, how long? Any scientific evidence for how it's used in COVID?
Brilliant, absolutely brilliant question, and such a pertinent question to ask at the end. I'm very grateful for that. So proning is in 4 stages. Proning, first of all, the most useful bit of most effective is proning, as in proning on your stomach, and that on your abdomen, lying on your tummy. That should be for a minimum of 30 to 45 minutes. Ideally, initially it can be difficult, but it makes a massive difference because most of the lower lobe and most of the consolidation is to the periphery, and the lower lobe is towards the periphery, and most of it is toward the back. After the 30 to 45 minutes, you need to go to the lateral decubitus position on the right side or left side, 30 to 45 minutes, and breathe, take deep breaths, and then in a semi-recumbent position, about 45 degrees angle, again 35 to 45 minutes, and then turn over to the other lateral decubitus position which you have not adopted earlier. So in this way, the circle needs to be completed, and this needs to continue. As far as scientific evidence, there are lots of trials which are coming through. Proning in patients who have respiratory failure, proning who are on a ventilator, it's hugely beneficial. And I would say that's probably the most effective treatment in COVID pneumonitis.
Thank you very much, Dr. Nishtar. Yeah, there's around 100 participants when it was maximum, and Dr. Nishtar now closed. It's a very successful meeting, really thankful. And Dr. Salman Nishtar, as he called Salman Bhai, can close the meeting now.
Thank you, Munavvar. I have only one word, and that is brilliant. It has been an excellent event. Thank you so much for sharing your data and all the information. And I'm delighted that we had an international audience here and a huge number and a lot of interest. It was so interactive, right? We had to actually stop because this could carry on really. So thank you to you, Munavvar. Thank you, Shoaib. Thank you for all the other organizers behind the scenes. Thank you to all the cardiologist colleagues that have given us the forum to conduct these academic meetings, and to all the participants. And I would like to take this opportunity to wish everyone Eid Mubarak. It's around the corner. And with this, I'll close the meeting. And I must say, Pakistan's in the world.
Thank you.
I just wanted to mention Salman Bhai and Shoaib Bhai. Really, it's such a pleasure and honor to be here to speak on this topic. And I must say this because almost every weekend I've done webinars for so many people, been invited, lucky enough to be invited around the world, but I've never had such an interactive audience. Honestly, I believe me, it's just wonderful. And the questions that have been asked and the level of interest and interaction is, mind blowing. It's fantastic. And I would like to thank you for inviting me. It's a pleasure to be here, and Eid Mubarak to all of you as well. Jazakallah khair.
I just want to say special thanks to Ehsan Khan. He is our ST4 cardiology registrar in Birmingham. He created the links for feedbacks and certificate. It's a great effort for. Thank you very much. Congratulations, Ahsan. Thank you. Eid Mubarak, Munawwar bhai. See you inshallah sometime in Facebook.
Assalamu alaikum wa rahmatullah.
Wa alaikum salam.